I have the distinct privilege of introducing virtually our final speaker, Dr. Sean Van Diepen from the University of Alberta. Sean is a good friend of mine and a true expert in cardiogenic shock. He'll be discussing the role of percutaneous mechanical circulatory support in hemo-metabolic shock. Sean, wherever you are.
Jason, can you hear me?
We can hear you, yes.
Excellent. Well, thank you for the introduction, and I'm really sorry I couldn't be there in person today. Omicron travel restrictions and schedule changes really conspired against me. So with that, I have no COIs, and these are my objectives today, and I think it's really important to at least define what hemo-metabolic shock means, and why is it important? Well, if we're not speaking the same language, or if someone's unsure about what that means, then we're really not going to be able to move forward with therapeutic suggestions. So I'm sure you've seen this today already, and this is the new SKY update published just a few weeks ago in JACC. And it had multiple revisions from the initial iteration. And what you can see here is that it started defining what the difference between SKY B and C was. And what you can see here is in SKY B, there was no hyperperfusion, but in SKY C, there was evidence of hypoperfusion. Now, where did this come from? And some of this came from interesting work from Jake Genser. And he did about a 10,000 patient retrospective analysis of all Mayo Clinic admissions. And they defined hypotension as low BPs or MAPs. And hypoperfusion was one of elevated lactate, increased creatinine, or low urine output. And what you can see here is that compared to people without any of those factors, isolated hypotension had a little bit higher mortality. Hypoperfusion was worse, and the worst was the combination of the two. But this really isn't a binary thing. It's actually additive, and there's gradations or a scale of these factors. Along the front here, you can see as the number of hypotension criteria add up, mortality increases somewhat. But when you go backwards on the z-axis here and you start adding the number of hypoperfusion criteria, then there's a huge jump in mortality, suggesting an additive effect. And I know you saw some of these slides earlier, but this is from the National Cardiogenic Shock Working Group. About 1,000 heart failure, 1,000 MI patients, and it was validated in the Danish Shock Danish Shock Registry. And what they did is they agnostically clustered cardiogenic shock phenotypes with machine learning techniques. And you can see here for non-congested, we're relatively hemodynamically stable. But I'll focus here on the cardiometabolic shock. What you can see here is that you had very low blood pressure, elevated heart rates, and end organ hypoperfusion with elevated lactates, decreased creatinines, and increased LFTs. And what you can see here is that when you go from non-congested to isolated cardiorenal to cardiometabolic, meaning multiple organs involved, this is complementary or additive data showing that the more hypoperfusion you have, the worse people do. So my hemo-metabolic shock key points is that hypoperfusion is the key distinction between SKY B and C, and that hypoperfusion is worse than hypotension, and the worst of all is when you have both. And the increased number of end organ hypoperfusion markers you have is really associated with increased mortality. So how do we stage the acuity and severity? Well, these are my thoughts only. So I want to stress that this has not been validated, and everyone is free to disagree with me. But when I think of the pyramid, when you go up the pyramid towards SKY A, you're more likely to survive with medical therapy alone. But the sicker you get, the more likely you're going to need a temporary mechanical circulatory support device, provided you're eligible. Moreover, the lower down this pyramid, or the higher the SKY stage, the more likely you're going to need a high flow device. And if you're in SKY stage EA, really probably eCPR is probably the most appropriate, although we haven't tested that in trials. And it also includes our therapy. So when you're an acute decompensated heart failure slipping from SKY B into early C, an isolated inotrope in a monitored setting is probably appropriate. But when you're arresting in SKY E, you're probably pushing epi. So our therapy, both pharmacologic and mechanical, will vary across this pyramid. It's also very dynamic, and that's what these arrows up and down the SKY pathway are meant to indicate. I always tell my trainees, never fall in love with your management plan. You've got to be nimble and you've got to be willing to change. And, how many times have you seen someone with mild stage C that, suddenly deteriorated on medical therapy? Those are the ones you need to progress to mechanical circulatory support. Likewise, there are stage D people that suddenly turn around on medical therapy. And in those cases, if they're rapidly getting better, it's not unreasonable to withhold the mechanical circulatory support that you'd initially planned for. So using this framework, my suggestion is that I think temporary mechanical circulatory support is mostly appropriate only in stage C and above, meaning C, D, and E, and not in those lower stages. All right, so what are the temporary mechanical circulatory support device considerations? Well, I'm putting this up to make fun of myself and perhaps all of us who love shock. I think we've all seen a number of patients that have gotten better just so quickly on mechanical circulatory support that would have otherwise died. And so we have a clinical conclusion, but we really need the data to support the role of routine mechanical circulatory support. And I'll show a little bit of that later. And this uncertainty is really reflected in the guidelines. Level of evidence C by the ISHLT. The AHA guidelines are saying you can consider it to enable recovery of organ systems when surgical risk is prohibitive, to support the facilitation of a definitive procedure like PCI, or to allow full candidacy evaluation. The only guidelines we do have, I believe, from the Europeans in ACS, you can see that they're at class 3 for routine IABP, and temporary mechanical circulatory support is 2B. And this uncertainty probably reflects the disparity or the differences in the use of devices. This is from the C3TN, and what you can see here is that the use of any temporary support range from 17 to 50%. And there's similarly in red here, there's quite a variation in advanced circulatory device use. So how do we choose a device? Well, I think there's a few things that go into our decisions. And here are the things that I think of. First off, is the person eligible? And I'll get to that in a bit more detail later. What is on your shelf and what does your team use best? I think that's very important, but often overlooked. How profound is the shock and what sort of flow do you need? I'll come back to that later. And the configuration, is it left, right, ventricular support, or both? And really, it's never too early to start thinking about your exit strategy. So here are 4 of the most common devices, percutaneous devices that I think are available worldwide. And there are so many differences between the devices, between cannulations and management strategies, which are probably beyond the scope of my talk. But really what I want to focus on is trying to match the depth of the shock and the perceived amount of flow that you may need. And obviously, the more inotropes, the worse the heart function, the lower the amount, the more you're going to have to move to this right. And this is a little bit more of an art of medicine rather than the science. The IBP Shock 2 trial, the best conducted trial of nearly 600 people in MI-associated cardiogenic shock. And what you can see here, there was no difference in the primary outcome of mortality and very little difference in hemodynamics. And this has certainly changed my practice and the practice of my colleagues. What I would point out, though, is that future studies are probably needed. This is a retrospective study from one center of nearly 2,000 patients with shock. And in the AMI population, you can see that about 50% had improved and 50% deteriorated after putting in a balloon pump. It's much different in the acute decompensated heart failure cohort, where about 75% of people had improvements. Now, this is not randomized and really just calls for more data in this different cardiogenic shock phenotype. What about Impella? I think we can all agree that it improves cardiac output, and in many observational studies, it also improves end organ perfusion. Does it improve mortality? Well, we're not sure, and the timing may matter. And in this one small meta-analysis, putting an Impella in prior to PCI in AMI-associated cardiogenic shock was associated with improved outcomes. A big caution, though, is that nearly 60% of this patient population came from an observation study. Again, this really calls for a larger RCT. There's also some harm signals here, and this is from the NCDR PCI registry. And what they did is they propensity matched nearly 1,700 patients with AMI-associated cardiogenic shock who were treated with balloon pump versus Impella. And And what you can see is that the Impella patients had more bleeding and higher mortality. Again, this was non-randomized, and this could be an unmeasured acuity bias, or it could be complications due to the device. And I think this really calls for, calls for properly conducted large RCTs. Well, ECMO, well, we know ECMO is growing, not only due to the pandemic with VV, but with VA. This is rather old data. It's about 5 or 6 years old, but the numbers in the ELSO registry keep going up. And cardiogenic shock is the #1 cause in the adult population. Do we know it improves outcomes definitively? I don't think so, but there's some data out there that is suggesting now maybe how we practice could at least be associated with better outcomes. And this is data from 4 countries, 16 center registry with nearly 700 patients that were propensity matched to those that were treated with ECMO alone or those with ECMO plus an Impella, so-called ECMELA. And what you can see is that ECMELA strategy had a 20% lower risk of mortality that seemed to persist across all subgroups. Big caution, though, is that in the ECMELA group, they had higher bleeding, higher renal replacement therapy, and higher rates of abdominal compartment syndrome requiring laparotomy. All 3 of these in multiple observational studies have been shown to be associated with worse mortality. So this begs the question whether the mortality benefit, despite the complications, could be due to a candidacy, selection, or treatment biases. Again, this just highlights the limitations of observational analyses. Okay, so how do we individualize the patient management? And I saw in the previous talk that this came up in the context of evaluation and prognostication. But in my view, this 3-axis Guy model can also be used to help determine what device they need. And, shock severity, I think of this as how much support do they need? What are the hemodynamics? How much vasopressors do they have? What sort of flow are you going to have? Risk modifiers to your right here. This is also the eligibility and an exit strategy. Well, age 29 is not 69. It just isn't. What are their comorbidities? Is there a strong possibility that they have post-arrest ischemic cerebral injuries? Do they have irreversible damage and organ damage? This should all factor into your discussions. And finally, the phenotype, I sort of think in many cases, this is somewhat like the configuration. Is it left, right ventricular, or biventricular? And what sort of support would they need or venting would they need if they were ECMO cannula? And these phenotypes that I talked about or the support are important because we can't assume anymore that everyone in the CICU is just cardiogenic shock. And this is from the C3TN showing that 20% of patients have mixed shock. And if any of you that have looked after devices, whenever you put a device, a mechanical circulatory support device into a patient with mixed shock, the vasoplegia component always gets much worse in the beginning. And this is something you have to anticipate and plan for in your decision-making. And it's not all AMI-associated shock, too. At least in tertiary units, those only make up 30%, and there is quite a diversity in underlying causes here. I'd also like to highlight how and who makes the decision. And I think the initial study by the ANOVA group showing cardiogenic shock team was genius in its simplicity that you had early activation of a multidisciplinary group with any evidence of shock. And what this group showed is that there was nearly doubling or mortality halved in the AMI shock group just by getting a group of people involved earlier. And this has sort of been validated on a larger scale as well recently in JACC. And what you can see here is that in 24 CICUs in the US and Canada, 10 of which had a shock team and the other 14 did not. Amongst the 10 shock team centers, you had a higher use of PACs, more advanced circulatory support, but most importantly, you had a lower risk of CICU mortality, again suggesting that a multidisciplinary team making earlier decisions improves outcomes. And we've seen this before too by David Berg's study. This Circ heart failure paper, I see a lot of people quoting what are the risk factors for mortality, but I think the most important take-home message is that temporary mechanical circulatory support early in the CICU course, meaning before you're setting into irreversible end organ failure, is associated with lower mortality. And this supports the earlier meta-analysis I showed you earlier. So what's upcoming? Well, We have the Euroshock and ECLS shock for ECMO, Danger for Impella, and we also have the Alt Shock tube for IABP in acute decompensated heart failure. All of these will help answer the question of efficacy or safety, but I don't think any of these will directly address the individual patient selection or risks that I've sort of highlighted earlier in my talk. So my key points is that early involvement of a shock team and shock management to help make decisions may improve outcomes, and that shock severity, risk modifiers, and phenotypes are all associated with prognosis. But I think these should also be individualized into temporary mechanical circulatory support decision making. But please don't forget what you do best and what's on your shelf should also factor in. And there's some future studies that are going to help define the efficacy and safety of temporary mechanical circulatory support. So with that, I will pause and happy to join in the chat or take any individual questions.
Thanks, Sean. That was fantastic. I'll turn to the panel to see if they have any questions to begin with.
Sean,
Rami?
thank you for that. You know, when I saw the title of your talk, I thought you were maybe going to talk about if you have a support strategy that is efficacious and safe, what do you do with the ensuing metabolic madness you see? And I just want to suggest that you, and I think you're a great leader in the field, and Naveen and others, call it cardiohepatic and not cardiometabolic, because we're going to have so many more phenotypes that are meaningful in the future. But I'm just curious, any idea of that aspect of the question, which is, let's say you have equivalent methods of stabilizing someone. I think Dan said this or someone else. What do you do next?
Okay, so yes, you have equivalent methods of stabilizing someone, and I don't think there are very few right or wrong answers. I hear a lot of people talking about bipella. If that's what your team uses most and that's what your team uses best, that's the first part of your question, then I think you should do it. But if you're like we are, and we're a high volume ECMO center, and we do a lot of ECMO and LAVA configurations, and that's what we do best, we're going to do what we do best in most cases. And I think that should really factor into the decision. So the second part of your question is what's next? And I think every case really needs to be individualized. And what comes next I don't do alone. As a critical care cardiologist in the CSICU and the CICU, I often work with teams of people, meaning transplant. We have a dedicated VAD team, the surgeons. And the what comes next depends on the clinical course. It depends on whether we cannulate it as a bridge to recovery, a bridge to decision, or a bridge to a bridge. And I guess I'm hedging a little bit and pushing on the specifics of your question, but it really comes down to the individual patient's needs and what the pre-cannulation plan was, and of course responding to complications, which I don't know about the rest of you, but I find are extremely common in this population.
I'll give you an example just of the question. I'm alluding more to somebody at the beginning hypoperfusion as a overarching theme of important to look at. If you're on full biventricular support, ECMO or whatever, what is the right pressor to use? Because I ask myself that question in the setting of how much is too much? They say, well, there's a modest amount of pressure. Well, why are they on any pressure? Why are they on any pressure? That's one. Two, do you think we should be using anti-vasoplegic drugs? Which, I guess I'm getting to that question because at some point, I think it was Biswajid that raised this. If you have equivalent tools on the shelf, and I'm sure everyone here has their tool on the shelf that they love the most to start and then the next and so forth. What do you do next so that you're not just seeing that total Billy keep going up and the kidneys doing et cetera, et cetera. That's what I'm wondering if you've already begun to think about that within your group of trialists, because that is what I'm looking for in the future, to be honest.
One magic drug. I know a lot of people will say that it's Levofed for everyone, and make no mistake, Levofed is my number one workhorse, especially post MCS cannulation. All of you will recognize that the post-cannulation vasoplegia is quite common, and it's what I use the most. But I don't think it's for everyone, and I think it really needs to be individualized. If it's vasoplegia, fine, maybe a little bit of norepi or vaso. But if you have a single ventricular device like a Impella CP, and the RV struggling a little bit, and I'm not talking to the point where they need biventricular support. I have a lot of the patients that I take care of are on dobutamine or milrinone monotherapy. So I think hemodynamically characterizing these patients and tailoring the therapy to the individual hemodynamic problem and to the cardiac phenotype is important. So again, it's a broad question, but that's my approach to it.
You know, Dr. Katz was mentioning that 4 years ago, he had questions about the classification. We don't know. That reminds me when I started my career with Dr. Fraser, I won't tell you how many decades it was, but when I started, he asked me a question. He asked me, BK, we know about pressure and volume relationship, but where is the flow relationship come into this? So what is more important, pressure or flow, and where is the interface? And I think so many years later, we still are struggling with the same thing.
Struggling with that too. Just a couple weeks ago, I was taking care of someone post-operatively with an LVAD whose maps were consistently above 60 or 65, but developed ischemic gut. But this was someone with non-pulsatile flow. And I think that sort of highlights the quandary that we have in some cases. Is it the pulsatility? Is it the pressure? Is it the flow? And I'm not sure. I think this is a big unmet need in this population, and I don't have a magic answer to that.
I think we have Dr. Burkhoff sitting here. He probably can answer this question better than others, because the pressure and volume correlations develop because those are the two parameters we could measure. Flow we could not measure at the time when those publications happened. But these days we have sophisticated ways of measuring flow, so maybe we can plug into the equation. Dr. Burkhoff?
I don't think that's the right answer. Maybe that's one reason why you get a cardiac power output, because cardiac power output encompasses both. And you have parameters like lactate. So, you know, it's all about its oxygen delivery, perfusion, meeting the metabolic needs. So, you know, in some patients, I don't know the answer. I don't know which, I don't think you would say one is more important than the other. You need both and the right balance.
Hey, sure. Oh, does someone else have a question? Oh, yeah, thanks.
So there's a lot of talk about hemo-metabolic shock. Can you give a difference between cardiohepatic and cardiorenal? In our experience, cardiohepatic patients do poorly compared to cardiorenal. So I think we need to define hemo-metabolic into different organ systems, and if you could clarify that a little bit.
Jason, was the question directed at me?
Yeah.
Sorry, I'm just...
Sean, he was asking about, defining cardiohepatic syndrome versus cardiorenal, and is there a difference in this whole sort of, group of hemo-metabolic shock? There are these individual organ system dysfunction that may play a more significant role, and how do we address that?
Yeah, so with all due respect to the National Cardiogenic Shock Working Group, I believe that there are distinct phenotypes that cardiorenal. We've all seen them, that the heart is bad and the kidneys are bad, and that's all that's going on. And we've also seen the people with multi-system end organ hypoperfusion, what we sort of call cardiometabolic shock. But I sort of view it as a gradation. We can create these phenotypes or these boxes, but there's a lot of people that go in between these two. And what do I mean by that? How many times have you taken care of a person with acute decompensated heart failure with renal dysfunction and mild congestive or ischemic hepatitis? Do we classify those as cardiometabolic or cardiorenal hepatic, or are they just cardiorenal? I don't know. I view this more as a continuum of risk rather than individually siloing these patients. And supporting that would be the Mayo paper I showed earlier, that the number of end organ hypoperfusion metrics that you have, the worse the outcomes. So I don't use those boxes per se that they have proposed. I sort of view it more continuously.
Well, great. I think we've sort of come to the conclusion, the end of our first session.